Good day, I am Anna Nolte, and on this two lessons, this one and the next one, we are going to talk about the interpretation of the partograph. Now, in this first lesson, I gave you an exercise where you had to fill in a partograph and then had to interpret the partograph after this. So what I'm going to do in this lesson is I will discuss the interpretation, how you fold the partograph in, and I will also discuss the interpretation of the partograph. So the objectives for this lesson would be to complete the partograph correctly, so we will check on that, and then to interpret the recorded partograph and recognize any deviations from the normal, and then also describe the specific midwife reactions that you were supposed to take at the appropriate time, and then also decide on, if necessary, a timely referral. Now, in your case, in the private hospital, this would mean to get the doctor or to let the doctor know in time that there are some abnormalities. Now, I'm going to switch the camera off for the next slides, just because the slides are fairly full, and I don't want my face to take up some extra space as well. So I'm going to switch the camera off. Okay, this is what your partograph should look like after you have completed it. And I will just keep a little bit quiet, silent, to give you a little bit of time to check whether you have done it correctly. What we will do then is we will take each part of the partograph separately and discuss it, so then you can also check what you have done wrong and what you have done correctly. And then we will discuss it and interpret it according to the 4 Ps, and then also decide on what management we should do afterwards. So I'm just going to leave this on for a few seconds so that you can just check what you have done correctly or wrongly. Okay, so if we go to the next slide. Okay, this is the second page of the partograph, which is the maternal part, the maternal observations and the urine and all the medicine, etc. that you've given. So I'm also will leave this for 2 seconds so that you can also check. This is the easier part to fill in. I think most of you would be able to do that, but I'll give you 2 seconds to just also have a good look at this. Okay, now when we look at the interpretation of the partograph, um, as I've said previously, the slides are very full, and I do apologize for that, because I want the different parts. We're going to do the interpretation here at 11 o'clock. So I want us to see exactly what happened at 11 o'clock on this part of the partograph, as well as on the maternal part of the partograph. And I want all the things that we wrote down regarding our interpretation here on the slide as well, so that we can see with one glance exactly what it looks like. And then the second thing that I just want to say before we start with the interpretation of the partograph, there's a lot of small variations in partographs that's been used by different hospitals, by the public sector, etc. But the basic principles of the partograph stay exactly the same. So you will see that this partograph might differ a little bit from the one that you're using at the moment, but it doesn't matter as long as the basic principles stay exactly the same. So if we look at the 4Ps, if you remember from the previous videos on the 4Ps, what they stand for: the passenger, the passage, the patient, and the powers. Now, if we start looking at the fetal heart now here at 11 o'clock. Now, the fetal heart is not really part of, as such, the progress of labor, like in the position and the presentation, etc., that determines how fast or how slow the fetus will go through the pelvis. But the fetal heart is very important for us in our determination of whether this patient can go further with her labor, whether it's prolonged or not. The moment that it's not going well with either the fetus or the mother, it doesn't matter what's going on at the progress of labor, something needs to be done. So if we look at the fetal heart, here we can see that the fetal heart had, on this partograph, the fetal heart is supposed to be recorded before and after contractions. And here you can see it had been done like that. Now, it's extremely important that the fetal heart rate should be recorded both before and after the contraction when the fetal heart's only auscultated. If you do a CTG, then obviously you will see what the fetal heart rate does during contractions. But if you just auscultate or listen with a Doppler to the fetal heart, it's extremely important to listen to the fetal heart before and after contractions. If you remember correctly from your CTG slides and videos that we've done, we have said that during a contraction, all the blood flow to the uterus is being cut off. And then most fetuses can cope with that. But if there is already, if the labor is going on for a long time or the contractions are very close to each other, etc., and the fetus eventually can't cope with that anymore, remember we've talked about the the oxygen in the blood goes down, the chemoreceptors in the fetus is being stimulated, and the fetal heart rate decelerates. So we get these decelerations immediately after contractions, and that is what we are after here. So if we don't listen to the fetal heart rate before, during, and after a contraction, we might miss these decelerations. So that's very important. So in this case, the fetal heart was normal, so we're happy that at least it's going well with the fetus. And then on this partograph, there's also a place to record the decelerations and the variability. That was good in this case. You can't remember. I see it on so many partographs. You can't record anything regarding the variability on a partograph if you haven't done the fetal heart with the CTG. You can't accurately determine variability without a CTG. So that's very important. Decelerations, you can see, you can pick up with when there was a deceleration there, and you will see it on the interpretation of the other partographs as well. Okay, so now we at least know that it's going well with the fetal heart, and I'm sorry about my phone ringing on the end of that slide. But now we're going to do the rest of the passenger regarding what's going on with this passenger. Will he come through the pelvis or not? So first of all, we see that this was a vertex presentation. So the baby faces with his head downwards. The position is a ROP position, right occipital posterior position, which tells us that the occiput lies in the posterior, on the right side of the posterior part of the pelvis. That already gives us a lot of information, because we know that in the case of occipital posterior positions, that labor is always a little bit prolonged, because first of all, in the case of occipital posterior positions, the head is not in good flexion. It's not in good extension either. So the diameter of the fetal skull that presents is bigger than in a normal anterior position. So that already makes labor to go a little bit slower, because as we've said, or as you will remember from your previous knowledge, basic knowledge about the occipito-posterior position, and it might be a good idea for you to just revise the whole mechanism of labor of the occipito-posterior position again. You will see that when the head is not well flexed, it doesn't fit well on the cervix, and that's why we get a poor application here. And also because in the case of an occipit posterior position, the occipit has to rotate either all the way to the anterior part of the pelvis, which might take longer, or it rotates directly posterior, which also causes a prolonged labor. So I suggest that you just go and quickly revise your mechanism of an occipito-posterior position if you can't remember it clearly. In this case, here we also see that the membranes were intact, that the membranes haven't ruptured. Yes, we've talked about the application, and we're not 100% sure about the size of the baby. It hasn't been recorded on any place where what they expect the baby to weigh. Now, if we look at the passage, that's now our second P that we are going to interpret. We see in this case that the cervix is 4 centimeters dilated. So this patient is still in the latent phase of labor. And we see that the engagement, this is this circle here, which tells us where above the brim of the pelvis is the head lying. And we see that the engagement is 4/5. Now on this part of the partograph that you can't see, if you go back to the first slide, you will see that this is a primigravida. And we expect in the primigravida that the head will start engaging from 36 weeks pregnancy already. So for a primigravida to come into labor full term with the head 4/5 above the brim, we know that this head is still quite high. It might be because of this occipito-posterior position with a not good flexion, but it might also be because of a CPD, a passenger pelvic disproportion, if I can call it like that. And together with that, we see that the descent of the fetal head, where the fetal head is according to the spines in the pelvis, it's -2, so it's still above the spines. But we see that there's no molding yet, which is a better sign, that the bladder is full, but she has passed 2 milliliters of urine. So we need to explore this a little bit more, because we have said that if the bladder is full, it causes an obstruction in the passage, because the head can't come past this or engage into the pelvis when the bladder is full. So we need to investigate this a little bit further. And according to our vaginal examination, everything was normal with the cervix and the vagina. So in total, there are some things here at the passage that worries us. The head is, the cervical dilatation is latent phase, but then we see that the head is still high. So we need to determine how this progress is going to happen further, and we need to further explore what is going on with this full bladder. When we look at the contractions, which are also very important to us, and that's the powers, obviously that's the power of labor, we see that in this case, the contractions are 30 seconds long, and there are 2 contractions in 10 minutes. Now, the question arises whether this is adequate. Now, when we look at the definition of adequate contractions, if you revise your previous videos on the Partograph, we've said that adequate contractions, there should be 3 to 5 contractions in 10 minutes, lasting from about 30 to 40 seconds. Now, in this case, there are 2 in 10 minutes, and they only last 30 seconds. So at this stage, I put a query there whether the contractions are adequate. Now, the patient is only in the latent phase of labor, so it's quite early in labor. So they might be adequate for the latent phase, and hopefully we need to see whether they are becoming more adequate later on. The definition of effective contractions means they might be adequate, but they also have to make or cause labor to progress. So if the contractions are adequate but there's no progress in labor, we say that the contractions are effective. So in this case, we can't really say, because this is only the very beginning where we see the patient for the first time. So we can't say whether the contractions are effective or not. If we look at the induction, augmentation, we see that there's no induction or augmentation. When we look at the fourth P, the patient, we have said that this patient is a grade 1. Her vital signs are normal. There's nothing wrong, abnormal in the urine. She hasn't received any medication or IV infusion so far. There are no signs of hydration or ketoacidosis or dehydration and ketoacidosis. We don't know. We'll have to find out how much pain she experienced. Can she cope with the pain? It seems that there's not a lot of pain if we just look at the contractions, the duration and the frequency of contractions. She's in the beginning of labor, so one can expect that she doesn't experience much labor. We also need to look at what position the mother is in. And these two things we will come to specifically when we do care about the care measurements. But in this case, if we look at the fact that the engagement, the fetus is still, the head of the fetus is still very high, we need to make 100% sure that this mother walk around a lot, that she ambulate, that she changes her position, and that in the process, hopefully, she might also help and encourage rotation of the occipito-posterior part. So if we say in general, this is there are some red lights saying to us that this might be a prolonged labor, of which one is the occipito-posterior position, the fact that the application is poor, possibly about poor flexion, the fact that the head is still very high, the fact that there might be a full bladder which might obstruct labor, the contractions we will see about, and as far as the patient is concerned, everything seemed to be normal. Now, when we look at the care measures now during up at 11 o'clock, what do we do with this patient? I think our biggest concern so far was that it's going well with the fetus, but the fetus is in a posterior position and the head is still very high, which are all factors that play a role in the progress of the labor. So we need to take all that into consideration when we plan now for the care measures. Now, if we just look at, I've just listed all the general care measures here that we normally look at during the first stage of labor. So now we know that this patient, we know that it might be a longer, and even if it's not a longer prolonged labor, but in this case we know that the patient might be in prolonged labor. We really need to take the fact that she might get dehydrated and that she might get exhausted and ketoacidotic at some stage into consideration. So we need to look at oral nutrition to provide her with enough glucose-rich fluids and small food that she can have build up her energy stores for later on when she's definitely going to need it. I don't think it's necessary to put up an IV infusion yet, because we can provide glucose and fluid by just giving her oral fluids and nutrition. It's very important that this patient should be ambulated and move around because the head is so high. And also we can give her put her in different positions. There's some evidence that different positions might change or help with the rotation of the occipito-posterior position. But definitely this patient needs to walk a little bit more round, so that gravitation helps us to increase the flexion of the head, which will obviously increase application on the cervix, which will increase the contractions, which will hopefully help with the engagement of the head and the descent of the head, and that will also eventually help with the progress of labor in total. It's far too early to rupture membranes. There's evidence that has said, if you also revise your previous Partograph slides, that it doesn't help to rupture membranes. And in this case, the head is far too high. The possibility of a cord prolapse in this case will be very high if you rupture membranes at this stage. I think this patient contractions she only has 2 contractions in 10 minutes and they are not very strong. So I think different positions, normal non-pharmacological pain relief measures should be very important at this stage instead of giving a pain medication like pethidine or something like that. This patient needs a lot of education on what to expect, how to move around, why it's important to move around. She needs lots of education on pain relief, how to the non-pharmacological pain relief measures that she can try. And then very important, as we've said, the bladder seems to be full. We need to find out whether her bladder is full. We need to encourage her to pass urine, and if she struggles to pass urine, we can insert the catheter. But we try not to insert catheters too soon and too often, because we also know that patients who are in labor have a higher incidence or the higher possibility of urinary tract infection. So that's the reason why we try and also get her and motivated to pass urine before we insert the catheter. Now if we go to 3 o'clock, what's going on at 3 o'clock? Now the patient was in the latent phase of labor, and in the latent phase of labor we're supposed to do the observations 4 hourly. So 4 hours after 11 o'clock was 1500 hours, and we found out that this patient was now 5 centimeters dilated. So she came from the latent phase, and we transfer it now to the active phase, and we make our cross here on the alert line at 5 centimeters dilatation, because the alert line tells us that this patient will now dilate 1 centimeter per hour further, and that's why we put this first cross, our first dilatation, on where it crosses the alert line. Say, for example, we did at 3 o'clock, the patient was 7 centimeters dilated, which would be here. We would have put it here on the alert line where it crosses the 7 centimeters, and that's where our active labor would have started, and this timeline, etc., would have started. So where the patient, we plotted on the latent phase base area of the Partograph, and then we transfer it to the active phase, and we transfer it where the cervical dilatation crossed the alert line. And in this case, it's here at 5 centimeter. So now at 1500 hours here, we look to see what's going on with this patient now. If we look again at the passenger, we see that the fetal heart rate here is still again normal. It's been still recorded before and after a contraction. There's a very little difference between the before and after a contraction, so it doesn't look like there are any decelerations. So we are happy with the fetal heart. It doesn't look like anything has been recorded here about the variability and the decelerations, but we see now that there's a C which tells us that the liquor is clear, so obviously the membranes have ruptured. So now we look at the presentation. We see it's a vertex. The position, there's a query here. Maybe they couldn't determine the position correctly, but it looks on this little vertex skull here that as if it's still an occipito-posterior position. So we just need to see that there's an occipito-posterior position, the application is still poor. So as far as that, there was not really any progress. If we look now further, if we talk about the passage here, We see that the cervix is 5 centimeters dilated. As I've said, the patient is now in the active phase of labor. Coming back to the fetal heart, we know now that we need to do the observations every half an hour. The maternal observations now the progress of labor needs to be determined every 2 hours. Okay, so now we see that the cervix, the dilatation has progressed a little bit. The engagement has progressed a little bit as well. The head has gone now from 5/5 above the pelvic, 4/5 above the pelvic brim to 3/5 above the pelvic brim. And the descent, the station, is also -1. It's still high, the head is still high, the head is still above the spines, but at least there is some progress, which we are very happy about. Molding is normal. We've seen that the patient has in 4 hours only passed 150 ml of urine. Now it depends on how much the patient has fluid she has taken in over these 4 hours. But this is very little urine for 4 hours. So we really need to determine whether this bladder is not full or not. And that might be one of the reasons why our descent and engagement is taking place slower than what it should be. The cervix and the vagina are still. Now when we look at the next two P's, the powers and the patient, if we look at the contractions, we see here that there are 3 contractions in 10 minutes. And they are more than 40 seconds long. So now I think we can easily answer our questions whether the powers are adequate and effective, because we've seen that there was progress both in the cervical dilatation as well as in the engagement and the descent of the fetal head. So that tells us that at least our contractions are getting better now. They are stronger, they are longer, and they cause progress of labor. There's still no induction or augmentation. And then if we look at the patient, the P's, the vital signs are still normal. We see now that there's protein 1+ in the urine, but which we are not too worried about because our blood pressure is still 100% normal. So this might be, we all know that often during labor and specifically you get protein in the urine that comes from the show, the vaginal discharge that's so much increased during labor that there's often protein. So we're not really worried about the protein in the urine as long as the blood pressure is normal, as we can see here. There was still nothing recorded regarding any IV fluids or medication, and there's we see that there's no ketoacidosis, yet the urine is still 100% normal, and she looks, the hydration looks normal. There are no signs of dehydration. Remember, we've said that the increase in the body temperature and the increase in the pulse might be signs of dehydration in the case of a mother that's in active labor, and we see none of that here. We need to find out how the mother experienced her pain. There's no indications obviously on the Partograph, so we have to find out. We have to observe, we have to see whether she can cope with her contractions or not. We've seen that they are getting stronger and obviously more painful as well. And we also don't know about the position of the mother. We have recommended that she walks around and that she ambulates and that she might take in different positions to help with the rotation of the fetus. So we need to follow that up and to see whether that's what she's doing or not. Okay, so in general, when we look at the 4 P's at 1500 hours, we're happier now. We see that there was progress of labor. We see that signs look more positive now. So what are we going to do regarding the care measures of this patient? We're still going to just keep on assessing her and making the right nursing diagnosis so that we can know which care measures to implement. We're still going to keep her well nourished, giving her glucose-rich fluids, etc., to see that she keeps on having enough energy for the more contractions, that she doesn't become dehydrated and ketoacidotic. We will still make her walk around and ambulate her. She might get more tired now because the contractions are getting stronger. So we still need to observe her very carefully for that and give her advice that she can get into bed from time to time, but then she must get out again and ambulate again, and teach her when we come to the different patients' educations about the different non-pharmacological pain relief measures, the different positions that she can take in during the first stage of labor to help with encourage the progress of labor, but also to help with pain relief. If she can't cope with the pain anymore, if she needs more than just pharmacological pain relief, this is the time that we can give her now some pain medication as well. We assume that this patient is going to be a normal delivery. She wants a natural delivery, so I'm not going to say anything about epidurals now. We've talked about the patient education, and as we've said, we definitely need to give attention to this patient's bladder. Good, so 2 hours later, it was time to assess the patient again. It's now 1700 hours, and we are doing our 4 Ps again. The patient had been assessed. We are here now. This is where 1700 hours is, where this red circle is going down. So now we see, if we look again at the fecal heart, here the fecal heart has been recorded and it's still normal. There's still very little difference between the before and after contraction fecal heart rate, so we're still very happy with the fetal condition. The presentation is still a vertex and an ROP. We still don't know about the application, the application is getting better now, so it's good now. It's going better and better here. And if we look at the dilatation of the cervix, we see that the patient is now 8 centimeters dilated here. And she's falling above this 8 centimeter cross is above the alert line that tells us that she's dilating even a little bit faster than the normal dilatation. We see that the engagement has improved here to 2/5 above the pelvic brim. So there's a lot of improvement here as well. The descent is +1. So all in all, everything is going wonderful. We are a little bit worried about the fact that the molding is now a plus. Remember, we've said that molding is how much the sutures overlap during the birth of the baby, and that might be an indication of CPD. But if we look at all the progress of the engagement of the head, the cervical dilatation, that's normal, we shouldn't be too worried about this plus molding. We should just need to follow it up very carefully. The cervix and the vagina is still normal. If we look at the powers, we see here is still 1700 hours. We still see that there are now 5 contractions in 10 minutes, which is bigger than 40, longer than 40 seconds long. So these contractions, what is the normal frequency of contractions? We say they should not be more than 5 contractions in 10 minutes. Otherwise, we talk about hyperstimulation of the uterus. So in this case, we're just on the border, but these contractions are definitely adequate and they are definitely effective. The patient's still not having an induction or augmentation. When we look at the patient, we see that this is 1700 here. Everything is also quite normal, except that we have a plus protein and a plus ketones now. So this patient is busy developing ketoacidosis now. Now, the big problem of ketoacidosis is that, as we've said, again, revise your previous Partograph slides, is that it causes the uterine contractions to be less effective, and it might also cause ketoacidosis, which influence the fetus. So we don't want any ketones in urine here, and we need to restore and recover this condition. They haven't given the mother any medication, IV or orally, except they have started giving here pethidine and atarax. So obviously the mother can't cope with these very strong contractions anymore, and they have decided to give her pethidine and atarax. The position of the mother we still don't know. Hopefully she is still walking around a little bit, but the pethidine and the atarax, it might be better for her to stay in bed now. We are happy that there is a descent and an engagement of the fetal head, so it's not so very important anymore that she walks around. But from time to time, it's still an occipital posterior position with still more pain. And if she can walk around and if she can change her position, that we get this ROP to change to a ROA, we will just be the happiest people in the world. So up to now, we are very happy that everything goes normal. When we look at the care measures now at this 1700 hours, I think we have discussed to a large extent many of them. We still obviously carry on assessing the patient. Now we need to be very careful because we see that there are ketones in the patient's urine. The one thing that one can do is to give the patient some more glucose orally, and hopefully that will recover the ketones. I would still not really give the patient any IV fluid at this stage because she progresses very well. We would kind of expect that she would be fully dilated within the next hour or so. So I would say oral nutrition here would be more than sufficient. If the labor is starting to get prolonged now because of the occipital posterior position, we sometimes know that the patient, this from 8 centimeter to 10 centimeter dilatation can take quite a while. So depending on whether that's prolonged, one can later think about IV fluids. But now at this moment, I think oral nutrition is normal. We have talked about the ambulation and the walking around. The patient has got pethidine and atarax. We need to see whether that is have a good effect, and we still it's not really a very good time to educate the patient now anymore because she's in a lot of pain, but we need to just make sure that where necessary we need to educate her. And again, we just need to make sure that this bladder stays empty. Now when we come to our last time slot, which is 1900 hours, I'm not going to go through all these particularly anymore. We still see this is 1900 hours here. We still see that our fetal heart is normal. There are no decelerations. The liquor is still clear. We see that the patient is now fully dilated, which we are very happy about. The engagement is 0. The head is it's +2, so the head is almost on the perineum. There's still only 1 plus molding. The bladder doesn't seem to be full anymore. We have good contractions. The patient will obviously be in pain, but this is now the stage for the second stage of labor. The contractions are still very effective. So in general, a very positive picture if we look at the progress of the labor, the fetal condition, the maternal condition, and good contractions. We are in general quite happy. So I hope that when you compare what you have done, how the way that you filled in your Partograph and how you interpret it, that you will be quite happy at the end of this interpretation and that you feel that you are competent in doing and interpreting the Partograph. If you feel still incompetent, I would suggest that you repeat this exercise or that you repeat a different exercise in the same way and make sure that you do understand it. Okay, go well, and then we'll go to the next interpretation.